We welcome all of you in our post-lunch sessions of NABH Patient Safety Conference 2024. And we are starting the post-lunch session with our session on diagnostic safety. In this session, we are going to have Dr. Parag Rindani as a moderator, who is CEO, Wockhardt Hospital. एक बार आपकी presence आपके तालियों के साथ feel होनी चाहिए. And let's welcome the moderator and all the panelists of this session. So Dr. Parag Rindani is here, CEO of Wockhardt Hospital, who will be moderating the session. In this session, we are privileged to have with us Padma Bhushan, Dr. B.K. Rao Sahab, past chairman, NABH advisor, Institute of Critical Care Medicine, Sir Ganga Hospital. I will request Honorable Padma Bhushan, Dr. B.K. Rao Sahab, to please come on stage and take his seat. So, आपकी तालियों के साथ उनको हम welcome करना चाहेंगे, Honorable Padma Bhushan, Dr. B.K. Rao. Then in this panel we have Dr. Om Manchanda, who is Managing Director, Dr. Lal Path Labs Limited. Dr. Manchanda, please be with us. Dr. Sandeep Shah, Founder, CEO and Director, Newburgh Supertech Labs. उनसे request करूँगा कि वो भी stage पर आएंगे. Dr. Sanjay Agarwal is also part of this panel, who is Secretary General, RSSDI, Head Department of Medicine and Diabetes, Ruby Hall Clinic, and Shri Mudit Dandavate, CEO, Co-Founder, Dozy. I will request all the panelists to be with us on stage, and I will be inviting Dr. Atul Mohan Kochar, CEO, NABH, and Chairman, Sir Rizwan Sahab, to come on stage and welcome the panelists, dignitaries on stage with a plant. So, आपकी तालियों के साथ हम वेलकम कर रहे हैं पद्म भूषण डॉक्टर B.K. Rao साहब with a plant, former chairman NABH, advisor to the Institute of Critical Care Medicine, Sir Ganga Hospital, and who has been key figure in healthcare since 1983. यहाँ स्टेज पर तो इन सब के लिए जो कि हमारे ऑनरेबल जो पैनलिस्ट हैं पद्म भूषण डॉक्टर B.K. Rao, डॉक्टर ओम मंचंदा, डॉक्टर संदीप शाह, डॉक्टर संजय अग्रवाल एंड मिस्टर मुदित दंडवते, इन सब को हम वेलकम करना चाहते हैं. और इन सब से एक रिक्वेस्ट ये भी होगी, क्योंकि एक ग्रुप फोटोग्राफ हर सेशन में हम लेते हैं और वही ग्रुप फोटोग्राफ फ्रेम करके आपके लिए हम तो खुद रखते ही हैं, लेकिन आपके लिए भी उसको हम भेंट करते हैं. तो आई विल रिक्वेस्ट फॉर अ ग्रुप फोटोग्राफ. So first we will have a group photograph, और इसके साथ साथ आप सभी की तरफ से NABH की तरफ से इनका वेलकम भी आपकी तालियों के साथ, बहुत ज़ोरदार तालियों के साथ, with full of energy. Let's welcome the dignitaries, panelists of this session, Diagnostic Safety. Towards safe, speedy, precise diagnostic every time is the motto and target goal of our NABH and whole fraternity who are part of this diagnostic sector. So I will request the moderator of this session, Dr. Parag R. Rindani, to start the proceedings.
Thank you very much and welcome to this exciting conference. I think this is laying a huge foundation in the patient safety movement in India. This has now become a norm, and we'd like to place on record on behalf of myself and all my co-panelists that NABH is doing a stellar job in terms of setting up accreditation standards, implementing these standards. And I think that this year's motto, ensuring that diagnosis becomes safer and hence lends to patient safety, is something that we all should be cognizant of and should have worked in from the time we got out of our internships. This panel is a very well-balanced panel. Unfortunately, I don't have Dr. Vidur Mahajan. He's down with a fever today, my radiology colleague. But this panel is a very well-balanced panel because I've got people from the diagnostic field, I've got people from the clinical diagnostic field, my clinicians, and of course, I've got somebody from the AI, machine learning, deep learning, facilitating things kind of for this thing. So without further ado, I'd just like to first of all place on record the fact that diagnostics is not just about, the diagnostic departments, the radiology, the pathology, the EEGs, EMGs, etc. There's a whole lot of diagnosis being done by the clinicians, the assessment of patients, the way in which they evaluate patients, and therefore it becomes relevant that we recognize their role, and even identification of the correct test becomes extremely relevant. So that's why, as I said, we've got our clinician colleagues, we've got our laboratory colleagues, and we've got our machine learning, AI contributing colleagues who will be able to put a full picture all together. So quick question to all the panelists, and you can answer them in random order. Just to set the stage, how would you define diagnostic safety in today's healthcare context, especially in the complexity of the medical condition that patients present with? What are the current key challenges in ensuring both speed and accuracy in diagnosis and also on the diagnostic side? Maybe I can start with Dr. Rao, sir. Sir?
I believe that medicine is all about uncertainty, because medicine itself is not a very perfect science. So safety in that concern is, or in that respect is, that the uncertainty should be reduced to the minimum by medical diagnostics, which essentially means that when we look at the safety and the cost and the benefit and the risk and all, the balance should be towards the patient, it should tilt towards the patient and not towards any other consideration.
Dr. Manchanda, sir?
I must say that when I was asked to come and be on this panel, and then later Dr. Atul asked my profile and posted it on LinkedIn, and a lot of my colleagues got to know that I am attending a patient safety conference. So I started getting calls from various sides, and my daughter actually called me, can you tell me what patient safety definition is? And it took me a little back, because in our day-to-day language I use the term quality, accreditation, but we don't use the term patient safety. And I actually looked up Google and a lot of other things, and then Dr. Atul's wife, she's a pathologist, she's with us, she sent me this whole 4 or 5 page presentation on patient safety, and I picked a very nice term there. It says that something which is preventable harm to the patient, if you can avoid that, that is patient safety. And it goes in many areas. It goes in the areas of how you talk to patient, how do you really be sensitive to gender, how do you look at all that. So since we are talking about diagnostics, so I'll actually come and pick up the specific example of our own operations. It is often said that 60 or 70% medical decisions are based on pathology tests or diagnostic tests. So just imagine if we get this wrong, and that is where the journey begins. Virtually the entire, if you want to go to north, you end up going south. And the cost of that change in direction can be humongous to the patient, both on clinical outcome as well as on cost. So to my mind, anything that can cause that harm to the patient is patient safety. Now, while we look at a lot of quality areas, etc., but I think I'll pick up one specific case which is very relevant in Indian context, and I personally experienced this. Indian healthcare is highly fragmented. You have a lot of small nursing homes, you have a lot of single unit run labs as well. As this healthcare grows, the challenge of scale is building up huge. Now, as a company, Dr. Lal Path Labs, some of you may not know, we nearly test close to 100,000 samples, patient samples every day. On an average, if you have 2 tubes or 3 tubes, you are testing nearly 300,000 tubes. And each tube, if you have 3 analytes, you are actually testing huge number of tests. Now, you can't even visualize the kind of operation that happens in the background. Now, while for a patient sample which is collected just about 2 tubes or 3 tubes, when it goes to the lab, it is mixed up in thousands of tubes, and you are completely lost there. So the point that I'm trying to make is that I think the challenge of patient safety is the way as the organizations become bigger, and I'm told many of you are from administration, many of you are from quality department, we'll have to continuously keep looking at processes as we do this diagnostic testing, and maybe from hospital from that point of view, that some of these errors actually can happen at any place. It can happen mix-up of samples, wrong barcoding, or there are many areas that can happen. To my mind, that sensitivity we need to bring in patient safety, where we can avoid unintended errors as we go along. Those are the points I want.
I think that was very crisp. Dr. Sandeep?
So, as Om has described that lot many patients' safety, how to maintain the patient safety or what we can give it to the patient. As a laboratory, see, we do have a lot many laboratory based in the hospital also. And when we talk about the private laboratory, they works in a different way, but with the hospitalized laboratory or hospital laboratory, they have a different way of working style. So here, when we talk about the hospital-based laboratory, they have to come in directly contact with all the patient continuously. And that is the real art starts. Because when we are talking about the private, maybe we are getting a sample from someone has collected, we are getting a sample. So many, it's a B2B business, B2C business, what we are talking about. But when we talk about the hospital-based laboratory, there is a different way of working. And the first thing is that we have to have a regular training of our staff. Regular training means, see, laboratory is known by their phlebotomist. So for me, I always believe that who is the important person in the laboratory? The person who is doing the manual work. Otherwise, everything is done by the laboratory with automation. The work who is doing the manually is the phlebotomist. And he should be trained continuously. Not only trained, we have to revisit his training also regular basis, how he is behaving. And that is the first and foremost thing for the laboratory, what we talk about. See, phlebotomy service includes the pre-registration, which will decide which sample collection is required. Nowadays, with the automation and with the, I think the AI people also sitting with a lot many softwares are working, lab software, or you can say LIMS and associated with the hospital. So pre-registration is a very good idea. So which is basically we are creating a system. Pre-registration means it already decides what type of the sample we should collect. Like many a times when we as a laboratory, when we look about it, we want to do the ammonia and sample you will get it in the plain test tube. So it's a horrible thing. Nowadays, lot many new tests, we talk about the viral load and we will get the serum. So those things now has been included in the LIMS system. Once you register with the test, when it has been ordered properly, you register the test, create a barcode, and create a proper collection system. That will solve lot many problems. Now that person is going to the patient. And when he is going to the patient, he should identify the patient. Because in the hospital, you will find the same name patient also lying next to next bed also. So we always believe, as all the system says that 2 identifiers are required, according to me, on the hospital-based patient, we require a minimum 3 identifiers, like the patient's age, patient's name, and other thing also. So that's the way we can go ahead. So 3 identifiers is required.
Yeah, this is going to throw a googly into many people's. We've just released the 6th edition of standards. But yeah, point taken, sir.
Yeah, so that's the standards. What we are talking about, the vacuum from where to collect, IV fluids are on or not. So those, all these things, because this will change straight away the patient's report, patient's results. So this thing is required for the continuous monitoring of the patient's safety part.
Thank you so much. Dr. Agarwal, from a clinician's point of view specifically, diagnosis safety or diagnostic safety, I'm going to use these interchangeably. They actually mean two different things. We are talking about getting to a diagnosis. We're also talking about multiple things. Your point of view, sir.
Thank you, Dr. Parag. I think I'm going to bring up the clinician's perspective. And for me, safety means how many patients can I send back home alive, safe, and happy. That's what, in today's world, when you've got so many challenges that are present there, and you know, many things can go wrong either in the hospital or in the outpatients. You have today all treatments that are getting algorithm-driven, they're getting more process-driven, they're getting more AI-driven. But what is most important is common sense. And unless you have common sense what to apply and use your human brain for coming to a diagnosis of a patient, you've seen many fallacies that has happened from AI-driven, from process-driven, and the patient ultimately is the sufferer of this all. So I'm completely in for technology, But I think most important is that you need to have experience and the common sense to treat a patient.
You know, it's an important thing here. It's a marker of the level of intelligence that we're seeing on the stage, that we've already moved from the first gear directly into third gear. We're already discussing what sort of intelligence should be used. I personally feel that ab initio, we should start using the manual intelligence we've been given. And then if we are, you know, Hindi में कहते हैं, यदि हम उसमें सक्षम हो जाते हैं, तब then we must use artificial intelligence. On that note, I'm going to hand over to my good friend Mudit, with whom I've been working on a very important diagnostic tool, so to speak, an early warning sign kind of a tool. Mudit, your point of view on what exactly is diagnostic safety? To you.
So first up, before I talk about the topic itself, right? First up, it's like a tadpole sitting in a tank of sharks, right? So it's a very humbling experience in itself. But to add to the panel, right? Panel has already talked about a lot of things, but I would really think about timely intervention, scalable operation, maintaining quality, regardless of time of day, right? Because, you know, Dr. Sanjay did mention about human intelligence, right, which is important, right? But the fact is human intelligence does sway with time of the day, right? We are not that aware at night. And that's the fact, right? And misses do happen at night, right? So how can we maintain a constant quality regardless of whatever is the time of the day? Whatever is the training of the personnel as well, regardless of the loads which are facing, right? Sometimes in rainy seasons, suddenly loads are high. That doesn't mean the quality should come down, right? And the fact that every patient is important, right? The COVID was indeed that experience that, you know, people can suddenly crash. We just can't take chances on just about anyone. And how can we ensure that each and every bed, right? And regardless of just the way in which they are coming in, but what Dr. Sanjay mentioned, right? Very important that every patient, right? How do we ensure that they reach and they have the highest grade of care when they require it, right? In a timely manner, consistently. And that for me is patient safety. And I think, just to add a little bit more flavor, Dr. Parag over there, I think we are talking about, you know, while we are talking about the patient safety of 21st century, we have to realize that a quarter of 21st century is already over. So I think what we need to talk about is the patient safety of 22nd century. And we need to take a leapfrog over there, right? Really, if we want to deliver at the scale of India, right? And that's what is important.
Okay, that's an excellent point. I think consistency, ensuring that we have similar results irrespective of whether it is Rosie on duty or Alayamma who's got 25 years experience, this is extremely relevant. And I think that adds a new dimension to diagnostics as well as diagnosis. My question is to Dr. Rao, sir. Sir, as you know, India lives in multiple places. We have India and then we have Bharat. From a clinician standpoint, how do you think we can have equity built in, reasonably equitable healthcare being provided in terms of just the diagnosis ab initio at both India as well as Bharat? I'm talking about, as you know, the urban versus rural divide. So can you share?
This is the most important thing. Any discussion has to be contextual. So when we are talking of whatever we are talking of high-end pathology, high-end diagnostics. And this is not what we are. Fact of the matter is that there are two worlds, one where we live and what we dream in. So if we talk of the next century, we are talking of something that we dream about. So let's, for the audience here, let's talk of what is happening on the ground right now, as of now. And that is, safety is not preventing errors. Safety has much, much more aspect to it. When a person in a village examines a patient, he has to make a diagnosis, and the safety of the patient is in his hand if he makes the wrong diagnosis. He's making a clinical diagnosis, he has no access to labs. So safety starts from there. And the person who's making it, what was his training, what is his caliber, what is his acumen, all that will decide whether he makes the right diagnosis or the wrong diagnosis. And everything starts, the safety or the outcome will be affected by that. But coming to your point, what should we do? It's simple, we should have a universal access to healthcare. That is for the policymakers, that is for the government, and that is for us, we the people. So if we decide to choose the governments who give that much spend in healthcare, we will have healthcare access, affordability, and all the quality, of course, anywhere and everywhere in India.
Well said, sir. Well said. My next question is to Dr. Om. Sir, there is this constant thing about the ads nowadays of the labs read about 64 tests in 1 hour, monsoon panel in 35 minutes. I mean, one understands the relevance and, the importance to focus on differentiators, so to speak, in the market. But to in your point of view, how does one really strike a balance between speeding up the diagnostic investigations and ensuring its accuracy?
Yeah, I think it's a huge challenge these days we all face. And not only in healthcare, you see in other industries where quick commerce is the buzzword. And everybody wants things very quickly, instantly. And that has caught on in diagnostics as well. And there are a lot of these days startups coming up, then they'll deliver the report in 10 minutes, 1 hour, and on top of that at a fraction of a price, which is very tempting for any person to order, but unfortunately that's also compromising with the quality. So in my view, I think most important thing is accuracy of test. You can't compromise with that just to make up for the speed or the cost. So some of it we solve it by our business model because we have a big lab, which we call it central lab, then we have the satellite labs. For a lot of these routine tests, we tend to go closer to the patient as much as possible, especially in fever cases because the timeliness is very, very important because especially in dengue, you want platelet counts, frequent testing that happens. That is where our satellite lab network comes very handy. But there are tests which are not very time critical where one can probably wait for the whole day. You give the sample in the morning and report goes in the evening. A bit of education that is required for all of us to give it to the patient. But I think it is definitely becoming a bit of a challenge where there are a lot of these days startups coming and pushing for quick service. But I think as a healthcare provider, all of us as an ecosystem, we need to educate that what is the medical value of something you want very quick. Just because you get report 1 hour early doesn't mean that there is a huge value you add to the patient or a medical side of it. Because if you get it wrong, then the cost of that is very, very high. But I think we try and solve it through education. We try and solve it through our business model.
I think that's well said. So in continuation, Dr. Sandeep sir, now you run a series of labs, and I personally have been to your labs, so I know that they're really nice and brilliant in terms of the work that you do. What are the systems and protocols that you have to reduce errors, misdiagnosis, within your laboratory system? Any examples you'd like to quote, sir?
See, in the continuation of my previous talk, what I was just going to talk about that one, hospital-based laboratory and again the private laboratory. So laboratory works with what you input. The first is a sample. You should have to have a right sample with you. That is a very important part. After having a sample, it has to go through the proper channel. So proper channel means the accessoring. No one looks at the accessoring part. If someone has made some mistakes somewhere, have you really examined or not? It means that demographic has been done properly, the test selection has been done properly or not. Those things are again a very important part. Every laboratory now, I think good laboratory, I'm not talking, sorry sir, but we have worked in the laboratory where all the automations and everything is there. So I may not be able to answer on the lower side what they are doing it. But the quality control is always there for all the laboratories. So there is no question about that part. But now the problem comes with the critical report. When there is what do you mean by, there are two different, either the test is critical or the report is, results are critical. So we always believe that, like the troponin, some tests which are very diagnostic, they are always considered to be a critical test. And critical test has to be informed positive or negative to the consultant immediately, which is very important. How to do it immediately? Now I'm telling you, we have a lot many problems in the hospital. Doctor's duty is changing. You do not have the phone number. None of the hospital gives a common number to that particular department. So the first and foremost thing, I always believe that whenever you work with the hospital, you ask the management that please allocate the common number to that particular place. Like ICU, that number has to be there continuously. So we should be able to inform. Very important thing is that how to process. Very simple way what we have done. Whenever we supply the vacutainers in the ICCU or when the emergency test is required, we always put the rate label, pre-rate label is always there. So whenever those samples comes to the laboratory, immediately they will be identified. Very simple thing, because any normal technologies also understand this is an emergency. And the rate label can identify immediately, can be processed immediately. So those samples will get the immediate priority everywhere. So it's a very small, simple thing to, as a management part. I believe that.
I'm grateful because this is a learning I'm going to take and implement in my group of hospitals at least. We didn't think of this. Sort of pre-labeling them stat, which makes a lot of sense.
Yeah.
Yeah.
So very simple. The laboratory will get always priority. Otherwise, as Dr. Om told, okay, there are thousands of samples. How to find out which is a important sample or we want to process it immediately? Because otherwise, laboratory will process all the samples in the same manner. So that is. Second thing is reassuring your results. And the delta check, which is very important now. Delta check means the patient is a permanent, there is some ID or patient is having an IPD number. That patient has to be traceable in the laboratory also continuously. If today I give the report of the 12 gram of hemoglobin and suddenly in the evening I got the report of the 8 gram of the hemoglobin, you should be getting a warning from the system itself. Okay, there is a change, sudden change more than 20%. So is there some fluid is going on or some bleeding is there or not? So there is a revisiting of the sample or the delta check for all the patients. So delta check can be set by the number or by the percentage. So whenever the patient is having a suddenly different report, it should be checked immediately and that should be pop-up as a pop-up. Okay, yeah, there is some variation. Talk to the doctor immediately. Those simple thing is that.
I think that makes a lot of sense, sir. My next question is, I'm sorry, but there seem to be some flies around. That's why all of us seem to be swatting our hands. Please don't take it as a mark of disrespect to the audience. Dr. Agarwal, sir, this is a googly question, and I risk being beaten up by at least these 5 people, if not anybody else. We have this traditional divide. The clinician and the diagnostician, or rather the laboratory, radiology, all on one side. Obviously, while one might like to think never the twain shall meet, but one does aspire and hope that at some stage, this gap is bridged. And all of us also understand that the laboratories and the radiologists, they keep saying that correct choice of investigation needs to be done. The clinicians feel that you guys don't get up from your armchairs and you'll become armchair pathologists and microbiologists and biochemists and don't get up enough and come to the clinical side to see whether what the patient is actually happening. I mean, what is actually happening with the patient. To this point, how do you think as a clinician, you're running an academic institution, a research institution also. How do you think that this bridge, this bridging can happen of this gap? And I know that there is a huge number of astute clinicians who will walk across, and there's a huge number of excellent laboratorians, radiologists who will walk across and actually go and see the patient. But that's not the norm. We know that. Your views on how we can actually bridge this gap?
I think that's an excellent question. I think the onus of responsibility lies on both the sides. I don't think it can be one-sided, because what happens when the patient comes to us and we make a clinical assessment of the patient, we come to a tentative diagnosis, based on which we decide that what kind of investigation profile that we want to look at, which will influence our decision to treat. Now, a lot of reliance happens on what kind of investigations that we get back. On the other flip side of things, unless we give a clinical profile to the radiologists, or for that matter to the microbiologists, they are unable to process accurately, because there could be multiple ways of looking at the same problem. And unless we give a clinical background to them, they are unable to process it. Correct? So it also relies on them that if there is no sort of history provided by the clinician, then they reach out and say that, okay, what is the background of this patient? Very often I've gone and looked at x-rays myself with the radiologist and said that this is how the patient presented and what is your take on this? Or for that matter, gone and looked at the slides, or for that matter, an echo or something like that. So at the end, it's like a total teamwork that you need to look at when you're taking the patient together.
Yeah, so in effect, both spouses will have to work at the marriage. It's not going to become magical overnight. I'm sure Mudit must be thinking that this is such a simple thing. I can apply at least 20 different tools of AI and get the lab data across to the clinicians, the clinician picture over to the laboratorians and the radiologists. And I would kind of tend to agree with you because the newer hospital information systems that come up have a hugely improved electronic medical record with computerized physician order entries, etc. Any views on how AI can help all of us?
AI can help?
This situation.
Or,
The situation of inadequate information being ported across to each other, non-timely reports occasionally reaching critical values as we have learned over the last 20 years. I mean, how do we actually bridge this gap?
So actually the answer is not AI to this, right? The answer to this, in my opinion, is more digitization.
Okay.
In fact, digitization, and when digitization happens, AI will feed onto that, right? So it's not the answer actually, right? So as in the data is the very building block of AI is what I'm trying to say, right? So if we want to create a very strong ML AI solutions, right, which solves and bridges a lot of these things, I think that digitization, that strong EHR system, right, is the very must of it, right? And I can give you one example from our experience at Dozy itself, right? When we wanted to create the AI-based early warning system, right, which can reach each and every patient bed, right, literally every bed, right? Our vision is that, every patient bed needs to be triaged with early warning system, right? And not once in an hour, like every minute early warning system should work, which can only happen through a technology, right? A human cannot do that. For that, the building block is a sensor that can take data 250 times a second without even touching the person, right? It has to be so convenient for the patient that actually patient doesn't feel like anything is, happening to them, and still we are getting that high quality data. And when we did that for 8 years, now in 9th year and 10th year, we are talking about the AI-based early warning system, reducing the code blues, reducing the bed falls, right, reducing the, sepsis events and so on. But that's where I mentioned, right?
Absolutely.
So AI is the later step. Digitization, is the very building block of that. So yeah.
But let's come to digitization. Let me take you up further on that. And while I belong to the haloed creed of laboratory personnel who had to undergo digitization, because let's understand why digitization got into labs and radiology early. Funda bahut clear tha. In the labs, things had to be built, and whatever had to be built got digitized first. Physician notes need not be billed with respect to the note getting entered, and you could raise a separate entry, and therefore that billing, that digitization has always taken longer. Today, of course, thanks to voice to text, etc., we're really finding a lot more of digitization happening on the physician side also, the notes, the other things, that's relevant, and I think I agree with you. We'll need to focus on comprehensive digitization first, and then layer it with artificial intelligence and see how much we can get. Because remember, ladies and gentlemen, we are sitting on a huge database. Indian database is huge, and forget the monetization of the database. It is time that we start producing our own data, our own statistics, rather than constantly quoting the CDCs and the AHAs and all of that. Quick question now to Dr. Rao sir. I'm sorry to be going in such a staccato mode, but it's just that this is kind of settling well, and we are coming to almost towards the end. My question to Dr. Rao sir is very, very simple. How do you feel we can involve the patient and the patient caregivers in terms of the entire flow of the diagnostic journey that the patient goes through, sir?
2-3 comments of what was talked earlier. One, where do the physicians come in contact with the labs in the imaging? Where the physician does not understand the alphanumeric report, he will walk up to the lab or to the imaging center and discuss the report with the person who's reported it. Because at the bottom of it is always written, please correlate clinically. And that is what the clinician doesn't understand. And then the patient has to be told that, look, in this particular film, this is where your lesion is. And he wants to be sure that he is not showing it on the other side. So he wants to discuss that. Secondly, we must understand what are we trying to achieve. Can we be 100% safe anywhere in our life? There is a cost to safety. To what extent do I want to be safe? Because I'm pushing up the cost of care. And when it comes to involving the patient and the relatives, the first thing they want to get involved is, what is my bill? So that is the beginning of it, that we should not do investigations which will not alter the treatment part, the outcome part, the flow of treatment. I can do 101,000 tests and say that these will all make it more safe, but at the end of it, nothing is going to change. So patients have to be told why we are doing the test, what will be the outcome depending on if the report is this or that, and then they are on board. But if you order a test and all of them are turning up to be negative, and if it is ever discussed with a colleague of yours or a peer of yours, and they say, why were these tests done, we have lost the game.
So I'm going to flip the same question over to you, sir. You're an endocrinologist. You work with diabetes primarily in a big way. And as we know, this is a lifestyle disease that requires maximum involvement with patients in terms of not just the diagnostics, the periodicity, the regularity of the investigations to be done, the coming back to the physician or the communication with the physician. How do you involve patients in the entire diagnostic spectrum, sir?
I think first and foremost, it is always good to spend time with the patient. What we are not doing is spending enough time with the patient because of the the amount of patient load that we keep looking at. Now, if you don't talk to the patient and explain to him his illness, along with his caregiver, of course, he's not going to follow your instructions. If you don't explain to him why a particular investigation is being ordered, he's not going to do it for you. He wants to know that why is he doing something. And today, it's a very educated world that we've got. And people want to know why something is being done for them. And if you sort of explain them well, I'm 100% certain that you'll have very low fallout rates of patient not reporting back to you. So it boils down to the fact that you have to spend time with the patient. Now, the flip side of it is that, okay, in this process of digitizations and paperwork, the time spent with the patient is getting lesser and lesser. And that is the sad reality, that, if you look at in-hospital patients also, we are pushed that do this paperwork, do this data entry, do this. But it's compromising the patient time. That is most important. Whereas the patient is what the focus always has to be. So I think there has to be a balance as to how much time can we focus on only digitization and paperwork and spend more time with the patient so that he understands and goes home as a happy patient and the caregivers realize that we have done a job what we should be doing.
I totally agree, and I think if you merge the two answers, I think it's very important. Counseling of patients in terms of what you're going to do for them. Of course, the financial aspects are relevant in today's day and age. And I think spending time with the patient, I think both of these are extremely, extremely relevant points brought out by both our senior clinician colleagues. My last question for Dr. Manchanda, to Dr. Manchanda is this. Sir, you run a large organization. You've got multiple centers. How do you maintain and how do you have you managed to sort of percolate that at the end of the day, it's the individual patient who is relevant, and how do you manage to sort of, because we know you to be, I mean, both the people sitting here, very respected laboratory chains. How have you managed to kind of ensure that not only the ethics, but also the individual character of the patient is something that you've maintained over these decades?
No, I think that's a great question. And I have, during my last 2 decades in this space, I've traveled widely and I've seen hundreds of labs. And in my view, if you randomly pick 10 labs, 9 out of 10 you'll find that everybody is using the same instrument. everybody is equally qualified, everybody using same reagents, but still some labs are better than the other labs. So what really differentiates them from not so good labs? I think it all flows from top. The kind of culture you set in the organization. At times, all of us run very commercial organization. At one level, you have P&L of the company. Another level, you have a patient, you have a quality, etc. But I think as a leader, you have to really walk the talk in the organization as to you mean quality. I think in the morning sessions, people talked about patient safety means patient centricity or customer centricity. I think fundamentally, if you put patient right in the center of everything, then I think you will have all the answers to running an organization. And to my mind, one single biggest problem that we solve is to help our clinician to diagnose accurately and also probably timely or early. If you keep these 3 or 4 things in mind, all your actions will be guided by these principles. And then you will actually have an organization which is running a quality organization.
Thank you very much. I think that, yes, Dr. Rao, of course, sir.
We've covered everything, but we've not covered the point of care diagnostics, which is outside the realm of labs. Please.
So, in fact, it was a 2-part question, but you kind of stole the thunder, but thank you for that, reminding me. 2 things. One, I wanted to speak to Sir, Dr. Sandeep Shah, sir, about the training aspect of laboratory personnel, both the physician, laboratorian, as well as the technical staff. And the second point which I have written down here is also that point of care testing is something which laboratories shirk away because one, nurses may not be knowing how to use the ABG machine or the HB hematocrit machines that are there, in the labs. Thromboelastography, which is usually done with transplant patients, etc., which is usually in the OT, out of your this thing. But technically, if you look at the NABL scope that you usually apply for under 15189, you do cover ABG also. So on the training aspects and on the point of care testing, how do you handle it, sir? Your own personal experience, sir.
So as my thing is always that for me, the phlebotomist is the most important person. So machines are going to give the right result, there is no question, if the sample is right. How you have collected the sample, have you taught your phlebotomist that how to collect? I'm just giving you a simple example for the ABG, if it's a venous blood associated or the arterial blood with a lot of air bubble, you will never get the right report out of it. So important thing is that at this point of care machine, the very important thing, how you have collected the sample. And I agree that the ABG, sometimes the physician is also collecting. And whenever say that basically there is a fight that machine is right or wrong, but machine is more or less 99% they are right, because nowadays they are very well calibrated, quality control is maintained everywhere. So I don't think so there is any problem for that side. So it's very important, the collection is a very, very important part.
Point of care testing, sir, any views on that? I know that you don't have, you have more laboratories which are standalone, but maybe I will pitch in with that. It's a nightmare. Dr. Rao, thank you once again. Point of care testing is a nightmare for multiple reasons. I'll start with the least reason. It never gets billed. Okay. Second thing is you can never finitely say when the QA/QC was done. Third, there is nobody responsible for the equipment. So point of care testing is a nightmare. We need to put in standards related to point of care testing and more importantly, pinpoint responsibility. The larger problem is that the majority of critical decisions are taken on the basis of point of care tests, which is where I think Dr. Rao was also coming from, sir, is that, yes, sir.
Just samples.
Yeah.
Point of care is imaging.
Yes.
Whole lot of decisions are made by point of care ultrasound and point of care x-rays. The interpretation is done by the clinicians and not by the lab and not by the imaging people, because they refuse to do a PA film analysis. They say we don't want AP, we want PA. And obviously our patients can't be positioned well. So they refuse, they say you interpret your own. Same is true for ultrasonics also. So that is a totally different ball game altogether and hugely impacting the safety of the patient.
True. One of the things that we have managed to do, and probably because our hospital is accredited by multiple accreditations, is that we've started privileging of consultants who are allowed to do point of care ultrasound. With COVID, we also got to know that point of care lung ultrasound is an entity which earlier was never really practiced, very vastly across hospitals. But we've started giving actual privileges based on trainings only as to who is allowed to do. But yes, there will always be, as you said, it's not a utopian world, so we have to be prepared and, battle out that.
Can I make a point?
Yes, of course, Dr. Parag.
So point of care testing from our point of view, from diabetes point of view, from the organization, RSSJ that I represent, we said that how many people have ever tested their blood glucoses, right? And we sort of, when we realized it, almost 57% of people are not aware that they have diabetes. We ran a campaign called the Defeat Diabetes campaign, which was run countrywide. And we said, can we sensitize 100 million people in 100 days? And this was monitored by the Asia Book of Records. And to our surprise, we could sensitize the 128 million. We went a step ahead. And we said, can we test 1 million blood sugars in a single day across the country? And this was with the help of many organizations. To our surprise, we diagnosed for the first time 18% of young adults who had diabetes. So point of care testing is not flawed. It may be flawed, but it's a good screening tool that we can use at.
Absolutely. With that, I'm going to, my last question to all my panelists. Look at your crystal ball in your hands. The one thing that you anticipate, wish for, hope, that in the next 5 to 10 years, technology, human resources, artificial/manual intelligence, Mudit, what do you think is going to be extremely relevant in terms of improving diagnosis and diagnostic safety? Randomly, any one of you can start answering. I have a point of view of my own, which I shall tell you when I wrap up. Maybe we can start with Mudit. Yeah, so I'll repeat the question. If you were to look in your crystal ball today and stargaze into the future, in the next 5 years, or 10 years, let's take, what do you think should be the utmost priority, or what do you think should happen to improve diagnosis or diagnostic safety? There might be similar answers, so it's quite okay.
Should I go? Yes. Yeah. So I think we discussed a lot of that, right? And whatever we discussed here today should happen. That is the idea. And I agree over there. So one is digitization that has to happen. That will become the building block for AI, and more importantly, a lot of data that we don't even know. One example being, and again just throwing off a random example, like breathing patterns, right? I'm pretty sure that right now we don't have enough data, like how much we have on cardiac patterns, on different patients, what happens during that, right? We have never even thought about that. Such things will open up new avenues for faster diagnosis, and I think these things will open up the new avenues of diagnostics.
I didn't give the caveat. This is supposed to be a 10-second answer. This is a rapid fire, because I'm already getting isharas from my good friends in NABH that we're supposed to wind up. Anybody next?
Yeah, I think we need to collect systematic data of the Indian population, and we should build guidelines of care based on what the Indian data is all about. And most important is see that it percolates to, training people at the last mile, because otherwise it just stays in the, in the publications and it's not enforced.
Thank you, sir.
Yeah, I think I'll probably add to this. There are basically two Indias. One India which has quality access to healthcare, and there's a huge part of India which does not have access. So I think the first is to how do we really improve access to diagnostics? We call it essential diagnostics. That is one area which maybe point of care is one solution, or there is something else to it. And there's another India where there is an access. I would say that technology has to play a role of in picking up a disease very early so that you can do something about it. There's no point in diagnosing it late stage.
Yes, sir.
Reducing the cost of technology, strategic planning, public-private partnership, accountability at the highest level.
Fantastic, sir.
diagnostic facility can be improved if clinician and pathologist or the diagnostic people work together and draw that clear-cut picture with the help of each other. That will be a great help to everyone.
So I think विकसित भारत के लिए पहले तो 2-4 शादियां करानी पड़ेंगी clinicians and diagnosticians. But I think I take from both our clinicians' points. I think diagnosis-driven care pathways or symptom-driven care pathways or diagnostic pathways is the need of the hour. We need to identify what we are going to test for whom. Today, whether we like it or not, there is this tag attached to us that doctors over-diagnosticate. I mean, they just ask for investigations randomly. Profiles sometimes don't necessarily always give what you're looking for. So we have to ensure that the positive predictive value of the test that we're asking for is reasonably high, either in pinpointing a diagnosis or in excluding a sort of diagnosis. And I think finally, as a country, we definitely need to work on cheaper and cheaper modalities of diagnostics. I think our IITs have given us a lot. Technology institutions need to work more with healthcare. And I know that for a fact that healthcare will support any technology that comes up as long as it is truly beneficial, as long as it is validated, and as long as it is relevant to the Indian diaspora. With that, I'd like to thank each one of my panelists for a brilliant panel discussion. Remember, ladies and gentlemen, at the end of the day, we are only, I think Dr. Agarwal said it, we are only as well known as the number of patients that go home safe from our hospitals. So let's not forget that, or get it right the first time right. Thank you very much, ladies and gentlemen.
Thank you very much, Dr. Parag Rindani, for moderating the session, and all the panelists. We are grateful to all of them. I will request Rizwan Saab, sir, and Dr. Atul. I think एक बार स्टेज पर आ जाएंगे डॉक्टर अतुल मोहन कोचर साहब, सीईओ साहब, so that we can present a memento to all the panelists, honorable guests. और so our chairman NABH Rizwan साहब and Dr. Atul Mohan जी, एक मेमेंटो और साथ में एक फ़ोटो फ्रेम भी, और उसके साथ जो एडिशनल बोनस है वो आपकी तालियां होंगी अगर आप सबको अपनी तरफ से हम मिलकर थैंक्स बोलें. लाइफ में इतना ज़्यादा एक्सपीरियंसेस इस फील्ड की और उसका इतना सारा हिस्सा भी अगर हमें मिल जाता है तो हमारे लिए एज QCI एंड NABH वी फील सो प्रिविलेज्ड कि हम जिस दिशा में आगे बढ़ रहे हैं उसमें ये सारी नॉलेज, इंफॉर्मेशंस, मोटिवेशंस हमारे लिए बहुत मैटर करती हैं और बहुत बड़ा संबल है. फ्रॉम ऑल अक्रॉस द कंट्री डिग्निटरीज, एक्सपर्ट्स फ्रॉम द फील्ड आर हियर, और उन सबकी डिलिब्रेशन से NABH जो क्वालिटी एश्योरेंस हेल्थ के सेक्टर में लेकर आना चाह रहा है और लगातार जिस पर काम कर रहा है वो उसमें हम बहुत बेहतर ढंग से आगे बढ़ पाएंगे और सफल भी हो पाएंगे. हमारे लिए ये मोमेंट बहुत इम्पॉर्टेंट है और हम सब इसको जिस रूप में भी इसको डॉक्यूमेंट कर रहे हैं और करेंगे उसको आगे जाकर कंट्री को उसका फ़ायदा मिलेगा, सोसाइटी को फ़ायदा मिलेगा, और हम सब इस बात के लिए अपने आप को बहुत प्रिविलेज्ड महसूस करते हैं. तो इन सब का हम बहुत बहुत थैंक्स कहते हैं, इन सब का बहुत बहुत आभार व्यक्त करते हैं. सारे पैनलिस्ट, पद्म भूषण डॉक्टर BK राव साहब, डॉक्टर ओम मंचंदा, डॉक्टर संदीप शाह, डॉक्टर संजय अग्रवाल एंड श्रीमती Danvate, and also Dr. Parag Rindani for moderating the session. Thank you very much to all of you. We are grateful to you. So Dr. Parag Rindani was moderating the session. Thank you very much, sir. Thank you so much, and we are grateful to our chairperson and the CEO also for honoring the honorable panelists.